Hi guys, welcome to the second episode of Mind the Crash Bleep. It's 7 o'clock, we'll just wait a couple more minutes and then we'll make a start. Okay, we've had a few minutes, so hopefully a few more people will join us as we go along. Um, but welcome to the second instalment of Mind the Crash Bleep. Thank you so much for joining on the live webinar this evening. If you do have any questions as we go along, please feel free to type them into the chat box on YouTube. And we'll either have a talk about the questions during the presentation, or we'll save them up for the end and go through things at the end of the case. So my name is Luke Austin. I'm currently an anaesthetics and ICU registrar. And just for those that weren't with us last week, or didn't have a chance to catch up on last week's episode on YouTube, we'll just talk a little bit about the idea behind Mind the Crash Bleep. We'll try and work through an adult emergency case presentation each time, stopping at multiple points to increase active learning and have a bit of time to think about what would you do next and what could you do in that particular situation and what might your options be. We'll have time for looking at questions, which you can add on the YouTube live. And we'll also have mental rehearsal of the relevant algorithms or even guidelines or procedures that might be relevant to that particular case. And I think this is a really useful quote for us, that the best simulator in the world is the human brain. And so by working through something in advance of an emergency actually happening, putting yourself in that situation mentally and thinking about how you would handle it if you had to make those decisions or deal with that kind of patient, you can increase your performance in the future. And just a little bit of the evidence for this whole idea of mental rehearsal. So in novice surgeons, mental practice before a virtual reality cholecystectomy significantly improved performance versus a control group who had only received a lecture. That was a study from 2011. And surgical cognitive simulation improved trainees' real-world performance on a surgical curriculum assessment just 4 months later, and that study from 2021. And another study that's probably even more relevant to our topic here of looking after crashing ward patients was that when residents were randomised to either 20 minutes of mental practice or 20 minutes of traditional ATLS instruction, those that had had the mental practice actually outperformed those that had the traditional instruction in a subsequent high-fidelity trauma simulation. So I think this is like everything, you probably get out as much as you put in. So try and visualize this scenario when we go through it in your mind's eye, thinking about it maybe in your own place of work with your own team members, and really try and put yourself in that situation. So let's give it a go. So you're carrying the crash bleep and you get a 2222 adult emergency to AMU. And when you arrive, there's a 58-year-old lady called Linda who's been referred into AMU by her GP with a headache, but she's not yet been clerked. And this is one of those AMUs where you can be directly sent in by your GP and actually bypass ED. So she's not come via ED, she's come straight in from her GP into the AMU with a headache. She's currently seizing. You are told by the nurses at the bedside that she has a past medical history of alcohol excess, hypertension, atrial fibrillation. She has type 2 diabetes and she's a smoker. You're the first one to arrive out of the crash team and no other crash team members have got there yet. And take a moment to think about how you will assess this patient. So I think most people are about to say let's do an A to E assessment, but I just want to emphasise the first thing you should do when you get to a seizing patient is take out your iPhone and start a timer. Usually a seizing patient won't have the defibrillator pads on them, so you won't get that advantage of the timer that started on the defib. And if you don't start a timer when you arrive, it's quite easy to sort of lose situational awareness of how far into the seizure event you are. So unless somebody on the ward has already done this and they can give you a very clear handover of when the seizure started and how far you're in, I really advise starting a timer on your own iPhone so you can see exactly how long this has been going on for. And then you're going to do your A to E assessment. So the airway, Linda's making snoring noises. She's got SATs of 89% on room air with equal air entry bilaterally. The BP cuff is not reading, but there's a heart rate of 117 on the SATS probe, which looks like a good trace, so she's probably perfusing her finger, and the central capillary refill time is 2 seconds. She's got generalised tonic-clonic seizure activity, and her eyes are rolling back in her head. She's afebrile, and she seems a little bit unkempt and dishevelled. So now imagining this scenario with Linda, how she is now, think about what your next action will be. So the first thing here is going to be to try and sort out the airway a bit, isn't it? Because she's got those snoring noises and she's actually desaturating with it. So often the first thing with these seizing patients is to try for an adjunct, such as a nasopharyngeal airway. So take a short moment to think about in your head how you're going to put this NP airway in, and then we'll go through it. And I've got a helpful video here, so hopefully the sound is going to work. If the sound isn't working for you guys, please just let me know in the comments on YouTube.
The oropharynx. Standing in this position, I'm in a good position to be able to see everything that I need to see. I've got some lubricant on the outside to help. And then with my non-dominant hand, I'm just going to pull the nose slightly back so I can see which nostril is largest. In general, we go for the right nostril first, but it's important you have a look to make sure there's no deviated septum or large inferior turbinates that may hamper you putting this in. Then we're going to gently insert the tip into the nostril, and I'm heading downwards, gently twizzling the tube, letting it gently seat itself in. I'm going to keep pushing, gently twizzling until the flange sits comfortably on the outside of the nostril. You can see in the side cut where the tip of the tube is. So if the tube was too long, potentially the patient may start gagging or coughing, in which case you'd remove the tube and replace it for a smaller size. Once the nasopharyngeal airway is in, it's important clearly to reassess the patient.
So the NP airway goes in, but remember the patient was actually desaturating on room air, so
Airway is in, it's important clearly to reassess the patient and make sure they have a patent airway and this is allowing them to ventilate. You may, even with this in, still need to do some simple airway opening manoeuvres to help support their airway. And also once it is in, you may need to support the patient by giving them extra oxygen.
So you're going to put that 15 litres of oxygen via a non-rebreathe mask onto the patient. I mean, as I said in the video, there may be some situations where even with the adjunct, you still find that you need a bit of a jaw thrust to fully open the airway, and you should hopefully then see the SATs start to improve on your SATs probe, which has stayed on the patient's finger. The reason usually that we don't use Goodell airways in these patients is that there's a risk of them damaging their teeth and they're sort of biting down when they're seizing on a Goodell airway, and it can also just be very difficult to get one in when the jaw is clenching during a seizure. So an NP airway is usually the best place to start. Okay, so you reassess from the top. So you've got a nasopharyngeal airway in, say it's a size 6, and you're doing a jaw thrust. SATs are now 100%, so they've come up nicely on your 15 litres of oxygen. Heart rate's 112 on the SATs probe. Linda's still seizing. And you haven't yet been able to examine E properly because you're still the only person there, and the rest of the crash team being a bit slow to turn up. So A, B, C, D, E when you're reassessing, and also D, E, F, G, don't ever forget glucose. So you ask the nurses to do a finger stick glucose and it comes back as 5.8. The nurses have very helpfully been trying to get a cannula for you whilst you've been sorting out the airway, but they say, "We're really sorry, doc, we can't get a cannula in anywhere." So what will you prescribe? And here's some options. So hopefully you've had a bit of a time to make your decision there. And you check your stopwatch, which you started, and you're now on 4 minutes and 11 seconds into the seizure. So actually, either of these would have been fine. So diazepam 10 milligrams PR, or midazolam as a buccal administration with 10 milligrams. And finally, the rest of the team arrive. Phew, that's good. So some more people now. So now that the rest of the team have turned up, one of them manages to get a nice green cannula in for us. So we've got some IV access. And another one of your colleagues gets an ABG. So that gets sent off to be run. And luckily, because you're in the AMU, they have a gas machine downstairs, and your gas result comes back as so. So looking through the ABG results, the thing that really jumps out, isn't it, is that sodium of 114. So that's very low, and that's certainly low enough to cause a seizure. We've also got a lactate of 12.5, which is not unexpected in the context of this amount of generalized tonic-clonic seizure activity. And the glucose is 5.4 in the gas, which sort of corresponds to the measurement we had on the fingerstick glucose of 5.8, which is okay. And time is now on 9 minutes and 21 seconds. So what are you going to do next? So Linda is still seizing, so you decide to give some more benzodiazepine. And which of these 5 options will you choose to prescribe? So you've got the cannula now, remember, so it doesn't need to be PR or buccal anymore. And you decide to go for the lorazepam 4 milligrams IV. Then one of the team says, what about the sodium on that ABG? And she's still seizing, so we probably do need to treat that. So everyone's in agreement you need to do something about that sodium. And what will you prescribe? And the correct answer to this part is 150 mils of 3% hypertonic sodium chloride, and that gets given over 10 minutes. So nurses start preparing that for you. But Linda is still seizing, it's still going on, and the team start to discuss what now after the benzos. We're now going to be hitting 15 minutes pretty soon. We're on 14 minutes and 46 seconds. So you have a think about what you're going to prescribe next. and the nurses take a look at Linda and give you an estimated body weight of 75 kilograms. So again, I've given you one of these questions with actually two possible correct answers. So either of these two would have been fine. So phenytoin, 1500 milligrams, which actually has to run over 30 minutes, or Keppra, otherwise known as levetiracetam, 4.5 grams over 10 minutes. So you actually decide to give the Keppra. So you give the 4.5 grams of Keppra, and that's run into Linda, and that goes nicely through the queen cannula. But unfortunately, she's still seizing despite that Keppra treatment, and we're hitting 26 minutes of seizure now since you arrived, which fits the definition of refractory status epilepticus. What do the next actions need to be? So unfortunately, given that Linda has now failed with 2 doses of benzodiazepines, her sugar has been normal, so there wasn't a need to correct it, and she's still seizing, as well as having had her hypertonic saline treatment, she's still seizing despite the 2 doses of benzodiazepine and the loading dose of Keppra. There's no choice at this stage other than to start preparing for an anaesthetic, which would be a rapid sequence induction. Now, the logistics of how you go about this and who needs to be called will depend on your own local hospital setups and who forms the crash team in your particular hospital. In many hospitals, the ICU registrar is a core part of the crash team and should therefore be in attendance by this stage. But in other places, you might just have the ICU SHO, or maybe an anaesthetics SHO, maybe an advanced critical care practitioner has attended. So it's really important that when you find yourself heading towards a refractory status epilepticus situation, if it looks like this is the way things are heading and you're potentially getting to a stage in the algorithm where you're going to need to be giving a general anaesthetic, the right people are called as soon as possible to try and start anticipating this event and preparing everything that needs to be prepared. Because you can't just click your fingers and anaesthetise these patients. Things need to be got together, equipment and drugs need to be gathered, and the right people need to attend. Because clearly intubating a patient on the ward is not without risk. So you decide to do another ABG prior to doing a general anaesthetic, and the sodium has actually increased from 114 to 118 after the hypertonic saline treatment. The lactate is still high, we're still seizing, and SATs are now 100% on the gas. So the preparations are made for the anaesthetic. You saw a few pictures there of various bits of equipment. It will all get extremely busy with a lot of people and bits of equipment and different drugs in the bed space. And it's crucial to use a checklist such as this one to make sure everything is there and everything is ready. And this one's called the Be at Ease checklist, which I think comes from Manchester, where they've quite nicely divided the different parts of doing the rapid sequence induction into preparing the equipment, the airway and the anaesthetic, having the right staff allocated to the correct roles, and verbalising the plan, checking whether there's any anticipated difficulty with the airway. I imagine most people on this call might not be in anaesthetics training. This is not something you need to know the ins and outs of. It's just to make you aware of what needs to happen and what will be going on in the bed space at this particular point in the status epilepticus algorithm. So I thought we'll have a quick look at what's going to happen as Linda goes off to sleep. So she goes to sleep with her anaesthetic drugs given. And then we have some laryngoscopy, we can see on the video laryngoscope here. Tip of the blade gets into the follicular, that sort of pocket at the base of the tongue, between the base of the tongue and the epiglottis. And they're putting a little bit of pressure on the neck here to bring the laryngeal inlet into view. And we can see the cords. You can see the cricoid cartilages there. Arytenoid cartilages there. And the entrance to the airway. And now the tube is going to come into view very shortly. And Linda is successfully intubated using the video laryngoscope. And then you see them blow the cuff up here on the tube. Okay, so Linda goes off to sleep with her general anaesthetic. And she is transferred for a CT head scan to look for a structural cause of the seizure. So she's taken through the CT head scan by the critical care team. And about 20 minutes later, we get the results of the CT head scan back, and radiology have looked at it, and here's her CT head scan. So what the CT head scan is showing is actually an acute on chronic subdural hematoma. And you can see down here, this is a sort of area of increased density of the acute hemorrhage bleeding into the chronic collection. And there's obviously quite a marked mass effect as well. So with this in mind, what do you think needs to happen next? So I think most of us will probably be thinking at this point about calling the neurosurgeons and plus or minus a transfer to a neurosurgical tertiary centre if we're not already in one, if the neurosurgeons think that there's an intervention that would be required, which could well be in this case. But I also wanted to highlight the importance of thinking about the drug history. So if we go all the way back to the information we were first told when we arrived at the crash call, you'll remember that Linda had a history of atrial fibrillation, and it turns out, yes, she is actually anticoagulated for that atrial fibrillation on apixaban 5 milligrams BD. And then we've gone onto her GP shared care record and we find out that she's also a non-smoker, she's not allergic to anything, and she drinks about 500 ml of vodka per night. And so everyone says, well, what about the apixaban? So have a think for a moment about what you're going to do, potentially, with this apixaban that Linda's been taken. So Barioplex is potentially the answer. So I would always discuss this kind of case with haematology. Usually they'll suggest a dose of 50 units per kilogram for reversal of a DOAC up to a maximum of 5,000 units. Most hospitals still sort of require a discussion with haematology for authorization to use this medication because it is quite expensive. And it does take a bit of time to mix up. It's not straightforward, so do ask for help and check whether the nurse that's with you who's done it before, because they may need help mixing it up from someone who has experience. It's not very straightforward, and I just thought I'd show you a bit about what's involved.
Firstly, ensure that the Berryplex and diluent vial flip caps are removed and the stoppers are wiped with an antiseptic solution or wipe. Allow to dry before opening the Mix 2 vial package. Step 2. Open the Mix 2 vial package by peeling away the lid, then place the diluent vial on a hard, flat surface and hold firmly. Take the Mix 2 vial together with the package and push the blue end straight down through the diluent stopper. Step 3. Carefully remove the package from the Mix 2 vial set. Make sure that you only pull up the package and not the Mix 2 vial set. Step 4. Now take the Berryplex vial and place it on a hard, flat surface. Invert the diluent vial with the Mix 2 vial set attached and push the transparent adapter straight down through the Berryplex vial. 1. Blue end Mix 2 vial to the diluent adapter straight down through the Berryplex vial. Step 5. Whilst holding both sides of the Mix 2 vial set, unscrew it into 2 pieces. Discard the diluent vial with the blue part attached. Step 6. Gently swirl the product vial until the product is fully dissolved, then place it back on your work surface. Do not shake the vial. Step 7. You now need to draw air into the empty sterile syringe. Then connect the syringe to the Mix 2 vial's Luer lock fitting and inject air into the product vial. While keeping the syringe plunger pressed, invert the system upside down and draw the concentrate into the syringe by slowly pulling the plunger back. Now that the concentrate has been transferred into the syringe, firmly hold on to the barrel of the syringe. Keep the syringe plunger facing down and disconnect the Mix 2 vial set from the syringe. Berryplex is now ready for infusion at a maximum rate of 8 milliliters per minute. We recommend you also refer to your local IV infusion protocol.
So even though it may not be us that's sort of usually doing this mixing, I just thought I'd sort of show this video to give everyone a bit of an idea of what the nurses are facing when it comes to mixing up this stuff, that it's not the quickest medication to prepare, and that they may need a bit of support perhaps from a senior sister on the ward who has done this before. So Linda gets her Berryplex, she gets her reversal of the apixaban. I always think it's important whenever you find a patient with an intracranial bleed to just ask yourself, is there anything that we could possibly be needing to reverse anticoagulants-wise? And she's referred to neurosurgery, who arranged for her to be transferred over to the neurosurgical centre, and she goes there obviously with critical care escort as she remains intubated and ventilated and anaesthetised. So we'll have a bit of a talk about some of these elements of Linda's case in a second, but to take a moment to think about for yourselves, like, what are the main learning points that you might get from this case that you could take forward. So the first thing I sort of really wanted to talk to everyone about with this status epilepticus case was how the definition of status epilepticus has changed over time, and it's changed to really emphasise the importance of good timekeeping and getting on top of the seizure as quickly as we can. So this was back in 2005 in the Continuing Education in Anaesthesia, Critical Care and Pain journal, and status epilepticus definition was 30 minutes of seizing. Or intermittent seizure activity with incomplete recovery, and going on for 30 minutes before it was labelled as that medical emergency. So in 2015, 10 years later, in the British Journal of Anaesthesia Education Supplement, which was the same journal that got rebranded, and they still said in 2015 they were publishing that convulsive status epilepticus is conventionally defined as 30 minutes of continuous seizure activity, or seizures without full recovery, And then they sort of go on to say, however, it's recognised that after 5 minutes of continuous seizure activity, spontaneous resolution is unlikely to occur. So treatment is advised to start at this time point. So by the time I was doing medical school finals, which was in 2018, we were definitely being told that status was 5 minutes of seizing. And here in 2025, you can see on this most recent guideline, which we're going to have a look at from the Journal of the Intensive Care Society, it says that status epilepticus is defined as 5 or more minutes of either continuous seizure activity or repetitive seizures with no intervening recovery of consciousness. And then this is the point they're making here, saying the time frame of the definition has been revised to emphasise the worsening of that prognosis and that we really need to get treatment started early. So I just quite interested to sort of think about, when exactly was this definition changed. So I did what lots of people do these days and asked ChatGPT, and was quite shocked to find that this proposal for a change in the timing of status epilepticus definition came back as far as 1999, and it really emphasises, doesn't it, that it takes a long time for things that are published academically to really make their way through into clinical practice. So it says that despite this paper being published in 1999, it took until 2015 when the International League Against Epilepsy endorsed this shorter time definition. So if there's one sort of take-home point for this case this evening, I'd really hope people sort of think about the timings and think about keeping a track of time and almost planning ahead for the next stage of the algorithm, thinking, if this step doesn't work, what am I going to do next? What am I going to do next? Have we got the right people here in the bed space if we get on to the next step of the algorithm? What are we going to do if this phenytoin or if this Keppra doesn't work? And that last paper, which I showed from the Journal of the Intensive Care Society, was this one here, published very recently in May 2025. New guidance for the acute management of status epilepticus in the adult patient. I think it's a very helpful guideline. I'd really recommend people having a read through it. It's not too long and it's freely available. And we'll just have a look at some of the key points now. So they break it down for us quite helpfully into stages. So stage 1 is 0 minutes, doing those basics which we did at the beginning for Linda. So maintaining and opening the airway, using adjuncts if you can get them in safely. Oropharyngeal can be okay, but usually the first thing to try is an MPA. Putting 15 litres of oxygen on the patient and getting IV or IO access. And checking that blood sugar nice and early. Sometimes in medical emergencies we say, don't we, let's just get the blood gas and then we'll see the sugar on the gas. I think this is not one of those times to be doing that. You can get a capillary blood glucose reading back much quicker than it takes to run a blood gas. Sometimes people have to take the blood gas down lots of corridors, and it takes a while for that result to come back. And if the patient's seizing because they're hypoglycemic, you really want to know about that as soon as possible. So just do a finger blood glucose as well as the gas and get your answer straight away, so that if they're hypoing, you can treat it. And then they talk about stage 2, so between 0 and 15 minutes is where you're giving your benzodiazepines. So we had a first dose, didn't we, where we gave some either diazepam PR, 10 milligrams, or we gave buccal midazolam. And then you can wait 5 minutes to see if it's going to have any effect. And I think realistically, in most of these scenarios, by the time you've heard the crash bleep, got to where you need to get to, whichever ward that is, or AMU in this case, you've got there, people might be panicking, you've taken the headboard off, moved the bed out to make a bit more space around the bed, and done your airway manoeuvres, and put the oxygen on the patient, it's often you're hitting 5 minutes already, and if they're still seizing after 5 minutes, you're going to give some medications. So we didn't have a cannula at that point, so we gave the diazepam rectally, and then you can wait 5 minutes to see if it's going to work, and if it's not worked, give your second dose of benzo. Sometimes I sort of quite often find people have given these quite small doses, so it's very reasonable to reduce the dose if the patient is particularly elderly or has a particularly low body weight, and they suggest here in this guideline reducing down to potentially 1 or 2 milligram aliquots if the age is more than 70 or body weight is less than 50 kilograms. But sometimes you do come across situations where we've been a bit underdosed for a normal patient of middle age, of normal body weight. And in those normal patients, it is better to just give the full 4 milligrams because you are trying to stop them seizing. The additional points they take us through here are to continue the regular anti-seizure medication, trying to get access to the GP shared care records if they've not yet been clerked, and see what they were on before they came in, if they were known to be epileptic, which wasn't the case here. Look for underlying causes, considering the history that you do have, and in our case we had hyponatremia, didn't we? Quite severe hyponatremia of 114. And I think putting it all together for Linda, the most likely thing is that with her, she was a drinker, wasn't she? Alcoholic. You do get subdural hematomas. You do get chronic SDHs quite a lot in this patient group, and she might have fallen over again potentially to explain the acute and chronic bleed, or it could have been due to the apixaban. And with both subarachnoid and subdural bleeds, you can get a syndrome of inappropriate antidiuretic hormone release, leading to a hyponatremia. So I think that's probably the story that gives us the best working theory of everything that was happening with Linda. And clearly, when you've got as bad enough to be actually seizing, you have to assume that the hyponatremia could well be contributing to that, and treat it, which we did with a dose of hypertonic saline. Once that first dose has been given, the patient clearly requires quite intense monitoring, usually in an HD or ICU environment, usually to make sure that the sodium doesn't increase by, for example, more than 6 millimoles within the first 24 hours. And sometimes patients might even need a bit of 5% glucose to make sure they don't overcorrect. And Linda would certainly have got some thiamine as well, wouldn't she, given her alcohol history? So then the last part of this guideline I sort of really wanted to highlight was this part where if you failed on the benzos, you're going to get an option of what do you give. I mean, when I was in medical school, no one was talking about giving levetiracetam in status epilepticus, and we were just taught it's going to be phenytoin, 15 to 20 milligrams per kilogram. But actually, as we'll come on to discuss, I think Keppra can be a really good option and has some advantages. So they say here that no agent has been shown to be superior to another agent, and the choice is to be patient dependent, which is true because every patient has their own medical conditions, and you have to consider the side effects for each of these drugs. But valproate is not normally one you'd see being given for status. I think most people at the moment would be between either phenytoin or Keppra. And this is probably why. So if you look at the appendix of this guideline. And the notes about sodium valproate, they do remind us should not be started in female or male patients under the age of 55 unless there's no other effective treatment. So, for quite a lot of patients, this might rule out valproate, and that's due to the risk of teratogenicity in females and infertility in males. And there's also these other issues with hyperammonemia, pancreatitis, thrombocytopenia, needing liver function monitoring. So, for me, I think valproate is not really top of my list in this situation. And what about phenytoin? That's the one we were sort of taught. I was taught in medical school, and that's one people have been using for a long time in status. Can cause cardiac dysrhythmias, and that's the reason why actually it's the infusion rate. Sorry, we go back to phenytoin. There. It's the infusion rate that could be the issue. I think, because you're sort of limited to an infusion of maximum 50 milligrams per minute for phenytoin, it can take quite a long time to actually get your dose into the patient. So it can even be 20 minutes to half an hour, depending on the patient's body weight. And clearly, if this part of the algorithm is not going to work, and you're not, and if you find yourself in this situation as we did with Linda, where you're not getting them to stop seizing and you end up needing a general anaesthetic, it's better to know that sooner rather than later. So I think if we look at Keppra that goes in over 10 minutes, that's a real advantage that you can get this medication into the patient quicker, and find out where you are and if it's going to work or not. So Keppra on the whole has fewer side effects than those first two medications. It's important to note this caution about people with previous suicidal ideation, suicidal behaviour, and it has been known to worsen depressive symptoms or psychotic symptoms. But on the whole, it can be a good option with this dose of 60 milligrams per kilogram as a loading dose in status. If you do have a patient who's already on Keppra, and for example, let's say they've already had 1,000 milligrams, a gram of Keppra that morning, and then they're in status, what you can actually do is then top them up to their loading dose. So you could, let's say they've had their normal daily Keppra 8 in the morning, and you find yourself in the situation on AMU at 11 in the morning. You can work out 60 milligrams per kilogram of their loading dose, and just subtract that what they've already had in the morning, and then top them up to the max loading dose. So hopefully that was a useful walk through some of the key points from this new status epilepticus guidance, which was recently published. Definitely recommend people having a look at it themselves and sort of seeing perhaps how that compares to local guidance in your own institutions. With regards to these sort of choices between medications like Keppra and phenytoin, again, it's useful checking what your own hospital is doing at the moment and where your own guidelines are at with it. So that in general you can try and keep your practice in line with your colleagues in your own hospital. But more and more people are using Keppra now for status epilepticus. So does anyone have any questions that they'd like to ask in the comments? So if nobody's got any questions, just a bit of housekeeping. Please do take the time to fill out the feedback forms. It's really helpful for us. Let us know what you thought of this format, what could be improved. If there's something you'd like to see on these webinars done differently, that would be really helpful for us to know. And when you fill out the feedback form, you'll get a certificate to upload to your portfolio. So to do that, you just need to navigate in your browser to mindthebleep.com/webinar feedback. It will ask you to specify the name of the webinar you're giving the feedback for, which is Mind the Crash Bleep number 2. And then it will just go a few short questions. It doesn't take long to fill out, and then you'll get a certificate sent to you. This was the reference for that new status epilepticus guideline. And it just remains to say thank you very much to those of you who have attended in person this evening on the Mind the Crash Bleep live webinar. And thank you to everyone else who's watching this in the future and watching back on YouTube. The next session will be on Monday the 27th of October at 7 PM, same time, same place on Mind the Bleep's live YouTube channel. Thank you so much. Oh, and just remains to say as well, if anyone does have a case that they would like to present on a Mind the Crash Bleep session, maybe it's a case you've seen in real life that you want to adapt a few details for to sort of present some teaching points on the webinar, and you want to present a case that way, please do send an email to crashbleep@mindthebleep.com.